Hi, I'm Dr. Chris Burrett. Welcome to the ACO's A Different Kind of Psychiatry case presentation webinar. We're glad to have you. Today's presentation is entitled, A Single Encounter Had an Incredible Effect on a Teenage Boy, presented by Dr. Jackie Bosworth.
Hi, Dr. Burrett.
Hi, Dr. Bosworth. Good to have you.
Yeah.
Dr. Bosworth is a child, adolescent, and adult psychiatrist in New York City, where she also sees families and couples. She holds the position of Senior Medical Director at a residential treatment center in Westchester County for adolescents at risk. She is a clinical associate of the American College of Orgonomy and has authored numerous articles in the Journal of Orgonomy. So Dr. Bosworth, before we begin, I'd like to let the audience know they can ask questions in the Q&A section at any time while we're talking, and we'll get to them at the end. So, Dr. Bosworth, this incredible encounter, can you set the stage, let us know where you were and kind of how things developed?
Sure. So, I used to work physically in a residential treatment facility part-time, and that differs a little bit from where I'm medical director now, in that the children there, adolescents primarily from ages 12 to maybe 20 years old, have diagnoses of emotional disturbance, and they also have IQs below 70, which is very low.
I see.
So this facility has a campus where the children reside, and it also has a school, which is actually just above my office. So this particular day, I was called upon to assist in a restraint, in a physical restraint.
So the patients live there, have school there, and how long might they be there for?
Well, the average length of stay is about a year, though with COVID, it's been a little bit more difficult to place children afterwards, but it's a temporary setting for them.
And so what happened in this encounter?
So whenever a child is held in physical restraint, it's required by law that a physician come assess them during or after the restraint. So in this particular instance, I was called at the very beginning of a restraint, and when I got up there, I came into a classroom where the child was being held. And what I saw was a very large but somewhat naive-looking or young-looking boy. I would say he was about 6 feet tall and upwards of 250 pounds. And he was being held in restraint by 3 security staff. 2 younger men were holding each of his wrists. He was flat on the floor on his back. And a 3rd security staff, an older man, was holding his ankles.
So this wasn't mechanical restraints. This was staff holding him down, restraining him physically.
Correct.
And what was this young man's name?
Stevie.
Stevie. And so when you walked into the classroom, what did you feel?
It was a bit overwhelming. In addition to the child being held in restraint, which I'd seen frequently before, the room was filled with school personnel, a nurse, and it was like a stage practically. It was intimidating initially. And I also saw that the boy wasn't being physically hurt, which was, the initial assessment that you have to make when you come into and evaluate a restraint. But he was moaning at the time, and he was clearly very unhappy, very miserable.
Was anyone else saying anything?
So initially, no, but after a couple minutes, I could hear Stevie making these moaning sounds and saying things like, let me go. And um, one of the security that was holding him said, we'll let you go if you can remain calm. And he kind of made an angry moan in response to that, but they did let him go, and he was able to back up against the wall and sit up at that point.
Did you say anything?
For a while, I didn't say anything at all. I was just observing. But when I felt he was calm enough, I sat down next to him. I sat down on the floor, folded my legs, and just looked at him, and he wasn't looking back at me at all. And then I waited and introduced myself, said, hi, Stevie. I didn't know him before. He wasn't a patient of mine. He was one of the other psychiatrist's patients, so I'd never met him before. And I told him who I was. And again, he just wasn't looking at me at that point at all.
Dr. Bosworth, what I just heard you say is you walked into a room with a restrained young man who's maybe twice your size. I know the audience can't see how big you are, but you're not 6 foot tall and 250 pounds. And you didn't know him. You knew that there was some kind of something that happened that he needed to be restrained. And I heard you just go in and sit next to him. That stands out to me. Maybe you could say something about that.
So there's always fear involved in a situation like this. I mean, a child would not theoretically not be as restrained unless they were a danger to themselves or to someone else. Mm-hmm. And, I certainly didn't know what precipitated it at this point. So I didn't know how much the potential for violence was. But I was observing him, and mainly I saw that this child was suffering, that he felt defeated. He looked like he felt defeated. He was moaning. Didn't look like he was in acute danger at that point, and I felt comfortable enough to sit next to him. But yeah, I guess in a way it was taking a chance. There's also the security staff right there, and if anything were to happen, there would be some sort of a warning usually, and I could back away if I had to.
So you use your initial observations both to kind of see where Stevie was after the acute episode, to see how the staff was, to develop some comfort, and also know that maybe that's what you had to do. Is that?
I'm not sure what you're asking, Dr. Burt. Can you?
What I heard you say, I want to make sure I'm on the same page, is you used your observations kind of initially to develop some certain level of comfort with the situation, knowing where Stevie was, where the staff was, that they had your back, if he was going to be more aggressive. And also, it sounded like you sensed that being close to him and not taking charge and being aggressive yourself was what Stevie needed.
Yeah, I mean, mainly I wanted to see if there could be a better resolution to what was going on at that moment. And I very much identified with how much this child was suffering and unhappy. And I didn't feel threatened by him in any way at that point.
And so what happens next?
So after I sat down, again, I did a lot of waiting, and he wasn't making eye contact with me at all. But I did notice that he was breathing kind of with a jerky motion and, kind of struggling and still making these moaning sounds. So I told him, just breathe deeply. And that kind of, he did that, and that kind of brought out more of his moaning, whatever was held within that moan. And I believe it was anger, defeat, misery, sadness, a combination of emotions.
Did he look at you? Was he lined up with you?
Still not looking at me at that point. So I think I tried to make some connection, and I said, I know this must be very hard for you. And at that point, he started crying a lot louder. And unfortunately, or maybe fortunately in the long run, the nurse that was in the room standing close to us said, calm down, calm down. And I felt that that was very wrong, a very wrong thing to say and counterproductive, not helpful to him. So I told Stevie, you can cry as loud as you want, in a very loud voice. And, I think that was very much what he needed to do, because he immediately started crying a lot louder and looked at me even. At which point, after he stopped crying briefly, I asked the nurse to give him a tissue, which was right next to her, and she handed it to him, and he kind of blew his nose and passed the tissue back to her. So it was indirectly a way of getting the nurse not to tell him to calm down anymore.
Yeah. How did you come to that conclusion that that's what he needed?
It was written all over him. You could, again, something about this child's, I don't know if naivety is the word, but there's something so direct about him. Like, it was all there to see. You just had to look for it. And again, I saw that he was quite miserable and even a little fearful. And I said to him at one point, when he started looking at me, no one's going to hurt you, and I even said, I don't even know what happened. And at that point, one of the security staff said that he was in class and he started throwing chairs at people.
Oh, wow.
Yeah. So that statement seemed to trigger him, because at that point, Stevie looked like he was going to lunge for the older security staff in the room, whose name was Mr. Smith. And, but then I realized fairly quickly it was more of a nonverbal statement on his part, because he immediately backed up against the wall. He was just showing an emotion by doing that. And so I said to him, Stevie, why are you so angry at Mr. Smith?
Dr. Bosworth, what was he showing with that lunge?
He was showing anger towards this man. The other security staff had just told me that he had been throwing chairs, and that triggered him, and he started to lunge for this Mr. Smith, the other.
Angry gesture.
Right, but it was a gesture, because he then backed up against the wall. So again, I asked him why he was so angry at Mr. Smith, and he yelled out, "He punched me in the stomach." Yeah. Now, luckily, I knew Mr. Smith, and he's a very kind, gentle man. I knew he wasn't really capable of doing something like that. But I also know that in the heat of a restraint, it's kids are flailing around in a restraint. Sometimes, an elbow can hit somebody, something like that can happen. So I said to Stevie, I think it probably was an accident. I don't think Mr. Smith meant to hurt you. And Mr. Smith nodded at that point. But Stevie was still looking directly at Mr. Smith. And, there was still anger and distrust on his face. And I said to him, Stevie, I'm sure he didn't mean it. Do you think you could forgive him? I'm sure Mr. Smith is sorry. At which point, to my surprise, Stevie started saying, I'm sorry, I'm sorry, I'm sorry, over and over again himself. And I kind of realized that, this must be a child who's been made to apologize for things he didn't even do in his life, and it just kind of endeared me to him more. I felt real compassion for him at that point and how helpless he was in this room full of adults.
He really sounds like a helpless, large child. Yeah.
Yeah, exactly. So I said to him, Mr. Smith forgives you, don't you, Mr. Smith? Who, again, affirmed that and sat with Stevie for a while. He was still crying, and I asked him if I could hold his hand. He needed comfort at that point, and his helplessness and his agony stood out more than anything else.
Mm.
So when I took his hand, he really started to cry with abandon, and tears just pouring down his face. And it took a long time, but after several minutes, you could see that he was starting to feel better. His breathing was returning to normal, and he seemed much, much calmer.
Wow.
Yeah.
Did the other staff react to what was going on in the room with you?
There was a lot of quiet. I heard some, rustling about at some points. I think a couple people left even when he started to calm down. But they were all there observing. Nobody was really saying anything to him but myself at that point. Mm-hmm. And he was looking at me, which was important because I felt, I've gained some trust from him.
Yeah. Yeah. And how did it end?
So I offered him some options at that point. I said, we can go back to class, we can go to another classroom, and a couple other things. And he decided that he was going to go to the classroom nearby with one of the people in the room who he was close to, who he liked. And so we both stood up and walked to the other room, That was the end of the confrontation. That was resolved.
Yes, very good. And is this like other restraint interventions, restraint episodes? Was this different than other ones?
So yes and no. Sometimes I will not arrive on the scene until a later point in the restraint, and maybe the child's already calmed down or whatever, or isn't calmed down. There's even times when you can't calm the child down, and whatever's going on is so intense that they need to be sent to the hospital, or somebody called in. But that's unusual.
I see.
So yeah, it was similar to other restraints in that sense.
But what I'm wondering is if, that what that nurse said to calm down, if that was more the tendency of the interventions than what you did this time with Stevie.
Yeah, I think a lot of people, staff included, view these children as problem children and don't really see that no matter how irrational they may seem, they have real needs, and something was going wrong for them, and some need wasn't being met. And that emotions happen in people when they're frustrated, when their needs are frustrated, and if they don't get expressed, if they're not allowed to drain, as some people call it, the tendency to react that way again is even more, because it's a real need. And by draining those emotions, you're able at least to get to clarify any misperceptions that might be involved, because there's nothing standing in the way. So by the nurse telling him to calm down, she was just exacerbating his need, whatever that need was. At that time, I didn't know for sure.
Yeah. And you did help him calm down, but how you did it was, very important and specific.
Yeah, it was a different approach from what often is used, just restrain, try to distract them, do things to divert the anger rather than to allow it to come out in a healthy way.
Yeah. Now, did his IQ have any role in the intervention? Do you think him being lower IQ had an impact on things one way or the other?
I don't. The short answer to that is no, but I will say that sometimes children with a lower IQ don't have some of the sophisticated, more manipulative or dishonest defenses that a child with a higher IQ might have. So for me, he was easier to read than some children are. And that certainly helped me to see, what he was feeling and what needed to be addressed. Yeah.
Yeah. Yeah. And do you know why he was placed in that facility? How he ended up there?
I honestly don't know his specific case, but I can tell you that most of the children that come there have had some real negative history. Either they've been abused or somehow mistreated, abandoned. Most of them have had numerous psychiatric hospitalizations prior to coming to that facility. they're kind of not eligible to come there unless they've had some real trauma in the past.
I see. No, I haven't worked in a facility like that in years since I was in residency. But right when I was finishing residency, a lot of institutions were going to what they call restraint free, or like trying to really, really pull back from that. Um, have you seen that? Does it have an impact on patient care or how interventions like this happen?
Yeah, I'm a little bit more involved in that aspect as the medical director of a residential treatment center. And there's very strict requirements about what needs to be monitored in restraints and strict requirements on reporting. And there's also a much more intense level of training involved in staff, that would potentially participate in restraint. So certainly the physical aspects of a restraint are dealt with in a very concrete and upfront way. This is how you hold a child without hurting him, that kind of thing.
Yeah. I see. There's a question from the audience. What is the healthy way to get anger out of kids and young adults? How to help them get their anger out?
Yeah, that's a big question.
Yeah.
Because it's, it's situation dependent on one hand.
Mm-hmm.
There are places and times where it can't come out, and, you have to do the best you can to try to allow it to come out as much as it can in those situations. But in the comfort of somebody's home, there's certainly the ability to address it. And to do that, you need not to shirk from it. You need not to distract the child. You need not to find reasons why they shouldn't be angry without first allowing them to say what they feel. And that goes a long way towards discharging the anger in the first place. But you can even do things like telling them it's okay to scream, or if you're worried about neighbors, here's a pillow, scream into the pillow. Go punch a couch. There are things that you can physically do to address a child's anger and help them to get into a better place so that they can talk rationally afterwards and be able to figure out what's going on with them.
Yeah. Well said. I agree. Dr. Bosworth, anything else about Stevie's story or this encounter that you'd like the audience to know?
Well, I don't know how many people in the audience might be wondering about medical orgone therapists and what they do. But I chose this case because I feel that in many ways it illustrates a lot of the things that medical orgone therapists do, which is maybe in some ways different from mainstream psychiatry or psychology. Some of the things that I can specifically think of are getting a person to breathe, which helps them to make contact with their emotions, encouraging the expression of emotion, building trust, clarifying misperceptions, maintaining a position where you're meeting the person where they're at and not with some preconceived idea of what they should be doing or where they should be.
Dr.
And I
Bosworth, you literally met him where he was on the floor.
Yeah, that's true. I was talking more on a figurative level.
I know.
Yeah.
But I think even that your intuition of not having him come up to you, but you meet him where he was, that sounded important.
Yeah, I think, if you're too afraid, you're not going to be effective in a situation like with Stevie. But I've seen so many people talk about their patients with preconceived ideas. I'm not talking about medical orgone therapists, but people in the field, and provide what I call prescriptives, which are, well, they should do this and they should do that. And medical orgone therapists don't do that. It's important, critically important, for a patient to discover what they need to do for themselves. And by understanding where a person's at and observing and waiting till you're comfortable addressing things, you're in a better position to reach the point where a person can make reasonable decisions for themselves.
And that's how you started off this encounter, just by observing, just figuring out what's going on. And to me, that's the highlight, is just observing and seeing where things are before you do anything.
Yeah, I think we finished this discussion so quickly because there was a lot of observing in it.
Yeah.
Yeah.
One of the audience members basically saying that they appreciate you meeting this child where he was, and saying that in Missouri, it's not a requirement for a physician in this kind of situation for a restraint event. And she also, highlighted the importance of the nonverbal communication that, between you and Stevie, how important that was. So, job well done.
Not a question, a comment. Thank you.
Yes. Anything else, Dr. Bosworth?
No, I think that's it.
Well, this is a wonderful, concise intervention of medical orgone therapy in a restraint situation. So thank you, Dr. Bosworth.
Thank you, Dr. Burritt.
And thank you to the audience for joining us today. And a special thank you to the members of the donors of the ACO who make our work possible. I hope you'll join us for our next webinar, which is on Saturday, July 15th at 4 p.m. Eastern Time. Dr. Ed Chaska will present A Sexually Confused Young Man. Hope to see you there. In the meantime, I hope you'll listen to our podcast, the A Different Kind of Psychiatry podcast, and check out the Journal of Orgonomy. Thank you very much.